Hi, I'm Justin Riley. Today on Wisconsin Doctors, chronic and acute pain. When you are suffering from chronic or acute pain, what are your options for treatment? We're on location here at Upland Hills Health in Dodgeville to find out more, and my guests will include Dr. Jody McGraw. Dr. McGraw was originally from Dodgeville, went to school at UW-Madison, and received her trauma training through the U.S. Army at Fort Gordon in Georgia. She's been full-time active duty for 5 years and was honorably discharged in 2004. Also, Brian Lensmeyer, who is a certified registered nurse anesthetist and advanced practice nurse prescriber and known as the pain practitioner here at Upland Hills Health. Brian received his education at Seattle University, Walter Reed in Washington, D.C., William Beaumont in El Paso, Texas, and was stationed at Fort Bragg, North Carolina for 4 years. It's all coming up right here on Wisconsin Doctors on CW57. Stay right here. Welcome back to Wisconsin Doctors. We're here on location at Upland Hills Health in Dodgeville, Wisconsin, and the topic today is pain management. And here to talk a little bit about that is Dr. Jody McGraw from the family medicine practice here at Upland Hills Health. Dr. Jody, welcome to the program.
Thank you.
So I'm wondering if you can tell us, first of all, a little bit about your background, and then also a little bit about the spectrum of pain presentation, I believe is the correct term, that you'll find in family medicine from time to time.
Yeah, so my background is training in family medicine. I went to medical school at the UW in Madison, and my residency training is also through the University of Wisconsin-Madison Department of Family Medicine. I'm board certified in family medicine, and I also do obstetrics, so Brian and I overlap a little bit in pain management in that realm. The spectrum of primary care pain management in the hospital setting is really diverse. It goes all the way from OB care, where women may choose things such as Lamaze and breathing techniques, to IV pain medicine, to epidurals, and it's really an individual choice and an individual preference. And we work with all of those with Brian's help if we need epidurals or advanced pain management. We do circumcisions in babies. There are diverse ways to deal with that pain. We do local numbing, but also glucose drops, sugar drops, actually comfort the babies, slow the heart rate, soothe them, and many of the babies that I do circumcisions actually sleep through the procedure, much to the comfort of their parents as well. And we do end-of-life care, hospice care, and acute pain management during hospital settings as well. So that's kind of some of the realm, just a sampling of some of the things we do with hospital care and pain management here at Upland Hills Health.
And it's not, pain management isn't just for aging people, it's for the young, very young, as you mentioned as well, so
right.
That's very cool.
Now, Dr. McGraw, is pain a common symptom that you see in the family practice clinic?
Pain's a really common presenting symptom in a primary care practice. Some papers have suggested that 20 to 50% of what we see in primary care is chronic pain, and that's on top of all the acute pain that we see. So we may see things such as ear infections, sprains and strains in teenagers doing sports, fractures, cancer pain, end-of-life care pain. So we do a lot of pain management, and in primary care we really like to focus on wellness and injury and accident prevention. We start that discussion right at the beginning of a pregnancy, all the way through well-child visits, and throughout teenage years, especially, continuing to focus throughout an adult's life on ways that they can reduce pain and be strong, good core strengthening, proper lifting techniques. We really try to have a focus on wellness in primary care. That'll include not smoking, as I mentioned, proper lifting techniques, getting plenty of rest, and just overall having good wellness helps people to deal with their minor sprains and strains and injuries day to day.
Absolutely. And you mentioned a few of the things that you see in family medicine, in cases of pain and so forth. Can you talk to us a little bit more about some of the more common examples of pain that people bring in with them when they come to see you?
Yeah, so something we commonly see, especially with the end of the winter season, we see strep throat and sore throat pain, and that we can treat with local numbing and antibiotics. We see ear infections in children, again, antibiotics and sometimes some local numbing medicine with Tylenol and Motrin. The teenagers and athletes, more sports injuries, and we'll focus more on outpatient orthopedic rest, the rice mnemonic, rest, ice, compression, elevation, in addition to Tylenol and Motrin, all the way through adult pain issues. So really a really broad spectrum. It really encompasses a lot of what we see and do in primary care.
Pretty broad spectrum. Yeah, absolutely.
So Dr. McGraw, to help me help your patients more, how as a primary care provider do you evaluate their pain in the clinic?
So when a patient comes into clinic and they get roomed by the nursing staff, they have their presenting symptom and get their vital signs taken, and even the vital signs can be off if someone's in pain. Their respiratory rate might be faster, their blood pressure might be higher. It really even affects the cardiovascular system with acute pain especially. We'll do a really detailed and individual history and get all the details of their chief complaint and their pain symptom. Then we might do a really detailed or focused physical exam depending on what the symptom is. And after we've gotten a history and a physical exam, we might order lab testing to evaluate a little bit more in the blood work, or we might order x-rays if it's an injured limb, for instance, where we get imaging to look at that. We see migraines, so then we move on to the assessment and the treatment and make a plan from there.
We have to take a quick break, but Dr. Jody McGraw, we have some more questions for you, so don't go away. It's Wisconsin Doctors here on CW 57. Welcome back to Wisconsin Doctors. We're here on location at Upland Hills Health in Dodgeville, Wisconsin, and the topic today is pain management. And we're talking again with Dr. Jody McGraw, who is a board-certified family medicine practitioner and is also part of the obstetrics team here at Upland Hills. And Brian, you had a question about different treatment options for chronic pain.
Right. What in your clinic, what type of treatment options do you utilize for your chronic or acute pain patients?
Yeah, so acute pain will usually start with non-prescription medications. For instance, an ear infection or a sprain, or more milder forms of pain are often treated with over-the-counter medications like Tylenol and Motrin. For more difficult pains, sometimes we'll move on to, for instance, pain from shingles or diabetic nerve pain, neuropathies. We might use some of the specialized medications that help with those types of pain syndromes. And so there are medications such as Neurontin or gabapentin that can be used to help with that kind of pain. We also find that people that suffer with pain, especially if it gets to be more of a chronic pain, can sometimes get depressed as a result of their pain. And if someone is depressed at a baseline, their pain may be upregulated. So sometimes we'll use some of the antidepressant categories of medications are actually approved in pain management because they actually help patients' pain. So we can get into different medications in the tricyclic category like amitriptyline or nortriptyline, or Cymbalta can be used to help with those types of pain. So in terms of pain medications, we use those types of medicines for migraine headaches or moderate or moderately severe acute pain. Sometimes we can even give people comfort with a shot of Toradol, a form of a more powerful anti-inflammatory like a super ibuprofen type of medicine that can be an injection in the clinic, and we can get good relief of patients' pain with that medicine. And more chronic pain, we sometimes do end up moving into the realm of narcotics, but we certainly try to use everything short of that to treat the pain, with the goal of ultimately keeping the patient as comfortable as possible and getting them relief of their pain syndrome.
Yeah, so you try to work towards, or try every step along the way before going towards the narcotics route, in other words.
Correct.
Can you talk to us a little bit about some of the other options that don't involve medication? Because there's a number of different options that are non-medical or medicine options.
Right. So there's a whole bunch of modalities of things that can be used to help patients' pain. One of my partners is trained as an osteopath and does manipulations. So she can often do manipulations for various pain syndromes in the clinic. And so some of the manipulative treatments can be helpful. Some patients like acupuncture, and Upland Hills offers acupuncture services in their wellness center. Some patients benefit from massage therapy. There's physical therapy that can be helpful for pain. And then we sometimes get towards the referrals with the pain clinic. So there's a whole host of different non-medicine treatments that can be used in conjunction with pain, and often people that suffer, especially with chronic pain, will do better when we combine those modalities of a medicine plus a hands-on approach.
Sure. We just have a few seconds left, but I'm wondering, can you tell us at what point do you refer somebody to the pain management clinic?
Yeah. Yes. We tend to work towards referring to the pain management clinic when we're getting a patient with more chronic pain who's really struggling, and we're working towards what other techniques, and Brian will describe a little bit more some of the things that he can do that can really give people relief of both their acute pain and their chronic pain. And so he's an excellent resource to have available. If we have a patient struggling with the types of pain that his practice focuses on, we'll give a referral his direction.
Absolutely. And when we come back, we will be talking with Brian Lensmeyer, our pain practitioner here at Upland Hills Health. Well, Dr. Joni McGraw, thank you so much for joining us today, and thank you so much for the information.
Thank you.
Stay tuned. There's more Wisconsin Doctors coming up right after this. Welcome back to Wisconsin Doctors. We're here on location at Upland Hills Health in Dodgeville, Wisconsin, and we're talking about a not so pleasant topic today, and that is pain management. And I'm now joined by Brian Lensmeyer, who is a certified registered nurse anesthetist, I think I got it right, and an advanced practice nurse prescriber, and also known as the pain practitioner here at Upland Hills.
That's correct.
The pain guy. Well, welcome.
Thank you.
Good to have you here.
Thank you.
So tell us a little bit about your background and what led you to do interventional pain, and talk to us a little bit about what interventional pain management is.
Sure. So I did my anesthesia training through the military. I actually went through University of Texas and spent several years in the military doing anesthesia, where a big focus of military anesthesia is what's called regional anesthesia techniques. So meaning that instead of going to sleep for every surgery that we do, oftentimes if it's a wrist that we're working on, we can actually just make that wrist numb. If it's an elbow, we make the arm numb. If it's a knee, we can make that leg numb. So instead of putting the whole body to sleep, we can focus on the actual limb that's affected. So that actually led into an interventional pain practice. Oftentimes regional anesthesia involves putting a needle exactly where it needs to be on that nerve to make that arm, limb, or otherwise object numb and render it pain-free for surgery. So kind of leads into an interventional pain practice. We're not necessarily making that limb or joint numb for surgery, but we're rendering the pain that already exists in that limb a little bit more comfortable.
So it literally is interventional versus prevent. You know, the other part of it would be preventing pain.
Exactly.
This is intervening when the pain is already here.
Exactly. And interventional pain also means that you're essentially using a needle technique. There's all kinds of pain techniques, but oftentimes interventional is seen more of a, is using needles to render that nerve or limb pain-free.
Sure, sure.
Brian, you and I have worked together and shared patients that have suffered with pain syndromes. Once I go through the workup as a primary care provider and work through some of the situations and medicines and modalities that can help the pain, sometimes they end up where you and I end up working together with a referral for them to see you. Can you talk a little bit more about some of the things that you do in pain management for the patients?
Absolutely. There's a lot of your practice that overlaps with mine, which helps me. When you've sent a patient for, you talked about this earlier, about imaging or physical therapy, or any of those other modalities that you've already tried with the patient, that means that when you send them to me, I don't have to retry all those things again. If you sent me a patient that hasn't been through some of those techniques, I'll end up sending them as well to try the minimal invasive procedures to get their pain reduced. But once they've already had those workups, say they've had x-rays or MRIs from you, then we can go into more of the interventional side of pain management.
Yeah, absolutely. And what are the things that you can do once once Jody sends you a patient? What are some of the things that you can do that maybe they're not capable of doing on their end?
Right. As a pain practitioner, oftentimes we can tweak their medications just a little bit, and that's where that conversation comes in between the primary care provider and myself. I don't like to manage medications without their knowledge, so they have a good idea of what their patients tried in the past and what works for their patients in the past. From my perspective, I have some tools in my bag of tricks that might help them. Things that might be a little bit different than the primary care provider might do for the patient. And those are some of the more non-interventional techniques. When it comes to interventional techniques, that's where a lot of my anesthesia background comes into place. For example, epidural steroid injections, and there's a lot of different ways we can inject those steroids into the epidural space. We can do just plain nerve blocks, we can do trigger point injections, we can do sympathetic blocks, which is a variety of an epidural steroid injection as well.
I'm curious about the whole epidural thing because, you know, I hear that, and as a father of 2 young kids, I remember my wife getting an epidural both times. Is this something that is not limited to women who are in labor then?
It's the exact same thing, except it's the medication that we're using. When I use it for a laboring mom, we'll put in a medication that renders them very pain-free for that delivery. When we're doing this for an interventional pain procedure, we're using a lot more of a steroid that's going to work over a longer period of time. That local anesthetic that we use in obstetrics does not last that long, and as soon as we turn those infusions off, that pain control is gone. It wears off fairly quick. Within 2 to 3 hours, they're back to feeling normal. With an injection of just a small bit of local and some steroid as well, that pain relief can last a year, a month, 6 months. For a prolonged period of time, those steroids will help them with their pain.
Wow. We've got to take a short break here, but our guest right now is Brian Lensmeyer, who's the pain practitioner here at Upland Hills Health. We'll be right back with more Wisconsin Doctors. Stay tuned. Welcome back to Wisconsin Doctors. We're here on location at Upland Hills Health in Dodgeville, Wisconsin, and the topic today is pain management. And I should mention that Upland Hills Health has recently opened a brand new pain clinic here on site at the hospital. And so we're talking with 2 folks who are very well versed in pain management and helping patients deal with their pain. And right now we're talking with Brian Lensmeyer, who's the pain practitioner here. So, Jody, actually, you had a question about the different types of pain syndromes that are fairly common.
Yeah, so one of the common things I see in primary care is arthritis pain, and in our clinic we'll do cortisone injections in the knee or Synvisc injections. Sometimes we'll send them to orthopedics if they're a surgical candidate. Some of the chronic pain will come to you. What are some of the common things you see in your pain practice,
And I
Brian?
do see those same patients with the arthritis and the chronic arthritis pain. Oftentimes, though, when I see them, it's chronic arthritis pain in their back. Some of the joints in their back are inflamed or arthritic or just not functioning well, and we do those focused injections on those very, very small joints in your back. That's one of the more common things I see, and as you and I are both aware, that's oftentimes a younger or middle-aged patient presents to you with what we more commonly call the slip disc or a herniated disc. Those things heal on their own most of the time. Within 4 to 6 weeks, you see some healing and the pain is reduced, and that's what we consider an acute pain issue. And once that passes the 6 to 8 week mark and that pain has not subsided or is not going away, that's oftentimes when I get sent that patient with a slip disc, and at which point we'll start recommending the physical therapy. We'll try a couple medications to see if we can get that radiating pain to go away, and oftentimes it's radiating down one leg or the other. And at that point, if the the physical therapy is not working, the medications aren't working, and that's when we start applying some of our interventional practice methods, such as that epidural steroid injection.
Yeah, absolutely. Now, I know you talked a little bit about this, but I'm wondering if you can just kind of clarify, for me anyway, what exactly is the difference between acute and chronic pain?
Well, we consider anything less than a year or under a year's worth of pain is acute. Having said that, chronic is over a year, but that period between 1 to 2 months on a slipped disc turns into a chronic issue at that 6 to 8 week mark. It's obviously not healing on its own. We still consider that a chronic pain issue that should be evaluated and treated such as a chronic issue. Oftentimes those short-term pain medications that we prescribe are for that 4 to 6 week time period, and if it's extending over that, then we consider this more of a chronic issue that should be handled as such.
So if I'm experiencing, let's say, pain in my knees or something like that, because I'm a runner and it happens from time to time, if I'm only experiencing it for less than a year, then it's still considered acute pain, but if it's more, then it's chronic.
Exactly. This is definitely becoming a chronic issue. We see that oftentimes too, where a patient doesn't experience pain constantly during the day, but it's something that nags them when they're running or exercising or any physical activity. That's where they feel their pain. And that's still something that we like to treat because it interferes with their activities of daily living and the things that they want to do with their life.
Yeah, absolutely. So what would you say that the long-term goals are for the patients that you see in your clinic?
Primary goal is to reduce their pain. We say we want to reduce their pain by at least 75%, and we want to also increase their function, their ability to do the things they want to do. So for instance, if I get a patient that can't weed her garden anymore because her back hurts her too much or she's got pain in her leg when she's trying to weed, I want to get her back to that level where she can do that and function the way she wants to in her normal life.
Yes, so making sure that people have the quality of life that they're hoping for.
Absolutely.
Yes, absolutely.
And oftentimes a lot of these issues are lifestyle modifications, and I think Dr. McGraw, you had touched on this a little bit with stopping the smoking, the weight loss reduction, a lot of those just lifestyle modifications that need to be done to improve their pain levels, to reduce those pain levels and improve their abilities to function throughout the day.
And it may be true that sometimes that lifestyle change may not be the magic pill, so to speak, to completely get rid of it, but it could make a big improvement in their lives as far as the severity of their pain too, I would assume.
Absolutely. And I think Dr. McGraw also mentioned that cycle of more of the depression and the pain, that cycle, that it's a cycle that we try to interrupt.
Yes.
The depression is going to cause their pain to be worse, and their worsening pain is going to not help their depression. So that's the cycle we're trying to break.
Absolutely. Well, Brian Lensmeyer, thank you so much for joining us today, and thank you so much for the information.
Thank you.
Good to have you here. My guests today have been Brian Lensmeyer, who is the pain practitioner here at Upland Hills Health, and also Dr. Jody McGraw, who is working in family medicine and obstetrics here at Upland Hills Health. That's all the time we have for Wisconsin Doctors. From all of us here at Upland Hills Health and CW57, we're inviting you to live longer, live better. We'll see you next time.